morning to all of you. It's a pleasure to welcome you all to the first Dr. Agarwal's Grand Rounds. So everybody must be thinking, what is this really all about? Is this really going to be any different from the journal clubs which has been already happening? And why should we be made to present? That is, I'm talking about the consultant. And is this really the age to start making PPTs and start presenting? So I just have one humble request. It's like, just put all your thoughts to rest and just think, whom is this really for? So at the end of today's talk, I want you to realize that it is for us that we are going to do this presentation, and by means of this, we are trying to educate ourselves and also the others with whatever knowledge we have. So, and another thing is, we all know that a great talk always benefits with a great discussion. So I'm very happy to call our panelists for today. And surprisingly, we have a pediatric topic, and as Pratibha mentioned, we have 3 Ps in our panel: Dr. Pallavi from CMH, Dr. Pratibha from Velachery, and Dr. Preeta from Porur. Dr. Soundri ma'am, I think you can also come and join us. Okay. Yeah. So moving on, I would like to introduce our speaker for today. Dr. Manjula ma'am, a very bubbly, enthusiastic, character. A ma'am who proves her mettle not only, clinically with a profound knowledge, but also surgically. It's a pleasure to have you on board, ma'am, because within a very short notice, ma'am just agreed to go ahead with the talk. And being the team leader, I think all the team leaders for the other teams should really get motivated by ma'am's, the participation enthusiasm. So welcome you, ma'am, for the talk. Today's session will be moderated by Dr. Ashwin sir. Thank you.
Thanks, Karpagam, for the nice introduction that you have given me. Okay, today's topic of discussion, we put the lights on. Today's topic of discussion is amblyopia, the current concepts of management. Why is tackling amblyopia so important? If you look at the general population, the incidence of amblyopia is just 1 to 2%. But in the pediatric age group, every 2 out of the 5 children who walks into our OPD will suffer from amblyopia. So therefore, tackling amblyopia is one of the foremost things in the mind of a pediatric ophthalmologist as well as a general ophthalmologist. Now let's start off with a case presentation. This is a 6-year-old female child. Child has been detected to have amblyopia in the left eye. The vision is 20 by 400. This is the uncorrected visual acuity. The patient has already been treated by a pediatric ophthalmologist, and this is the correction given. The right eye a +1 sphere and the left eye a +5 with a -0.5 cylinder at axis 180. This child was uncooperative for patching, and with this background or scenario, the child was referred to us. So the initial findings on examination, the visual acuity with correction in the right eye was 20 by 20, left 20 by 70. Patient was orthophoric for distance and near on cover test. Retinoscopy, there is +1 sphere in the right eye. The left eye, you see there is a little more cylinder, 1.5. This is the manifest retinoscopy at axis 15. So we changed the subjective readings. So with 1 sphere 20 by 20, with 5 and -1.25 cylinder at 15 axis 20 by 60, the stereopsis is good, about 100 seconds of an arc. Word dot, normal fusion. Cycloplegia shows a little more. This is latent with manifest hypermetropia. Dilated fundus examination, all structures normal. The fixation in the left eye is central and steady. So all these things have to be seen in an amblyopic child. That is why I've depicted all the things that have to be scrutinized. It is just not visual acuity alone. So what is the diagnosis? It's a very straightforward diagnosis. No squint, refractive error, anisometropia, hyperopia. So this is a refractive amblyopia in the left eye. The child has been modified for the glasses. The right eye +1 sphere, the left +5.25 with a 1 cylinder at axis 15. You are going to emphasize on the continued full-time wear of glasses. We are discussing contact lenses. Why are we discussing contact lenses? Because we don't want anisoconia to step in and deter the amblyopia treatment. The child is ours and the mother declines. So let's see the follow-up of this child. What we do is, since the child is averse to patching, we start them on atropine penalization. You instill 1 drop of 1% atropine on Friday night, check for dilatation of pupil. If it isn't adequately dilated, instill 1 more dot. drop, and you ask the child to come for an in-office examination on Monday. You look at the visual acuity in the right eye, the atropine penalized eye, and you emphasize on own visual training activities like dot to dot and mazes. Let's look at the follow-up of this child. The first follow-up is at 4-week interval. The visual acuity in the left eye has now improved from 2070 to 2050 parts. You plan to continue the beacon therapy of atropine. You plan to continue with the home visual training exercises. Second follow-up. This is going to be an 8-week follow-up. Good compliance with atropine. Visual acuity in the left eye is improved further to 2040 with one line more, with one letter more. Stereo acuity is showing a lot of improvement from 100 seconds to 80 seconds. Now you plan to continue atropine therapy, but you start on computer learning activities. That would be jump start exercises. Okay, this is follow-up number 3, which is at 12 weeks. So you're following up this child at every 4-week interval. Now the visual acuity is 20 by 30. Stereops has more improvement, 60 seconds of an hour. But you find that now the mother complains there is a decrease in the visual performance at school. The child is having difficulty at reading because of atropine penalization in a good eye. So now you have to suspend atropine penalization. You give quality time patching, that is 2 hours patching daily after school, which includes some activities like your Michigan letter tracking. Let's go to progress evaluation number 4, which is at 16 week. Vision has improved to 20/25. Stereopsis is near normal at 60 seconds of an hour. You continue the quality time patching after school and weekends. Okay, 20-week follow-up. This is progress evaluation at 5. Visual acuity is almost normal, 20 by 20. RAM dot is perfect, 40 seconds of an hour. The same thing is going to happen, but now you can taper. You are not supposed to discontinue your amblyopia therapy abruptly, because you can have something like a recidivism happening. So you have to do a tapering of your patching. At this point of time, when you have near stereopsis, good visual acuity in the other eye, so this is the final progress evaluation, 24-week follow-up, almost 6 months interval, visual acuity is 20 by 20, normal stereopsis, stable acuity, you emphasize on full-time wearing of glasses, you monitor this child at 6 months of intervals, you're not concerned about recidivism because you're using full-time glasses, but you continue to recommend contact lenses. At this point of time, if there are any doubts, I think.
Anybody with questions regarding the case itself?
No, because the child is averse to contact lenses. The improvement will be faster if you are giving contact lenses.
So once the patient has got 20 by 20,
If you use the mic, just so that everybody
we are not
can.
doing patching.
No, once the 20 by 20 is reached, as you said, I saw in the previous few slides, you start tapering your patch. You don't abruptly. If the child has been using 2 hours, you make it 1 hour, then you make it half an hour. It's all within 8 weeks, I think. And then you can stop. Over 8 weeks, you can take. If
Every visit, you've not recorded the right eye vision. Atropinization was happening.
No, that is because I don't want it to be recorded. As a protocol, visual acuity is done every time.
No, that's what.
That's why we stopped atropine when the child complained of difficulty at schoolwork. That's the reason why it was stopped.
So, because occlusion amblyopia also should be.
Yeah,
thought of.
reverse amblyopia. It's called as reverse amblyopia.
You said that the child was given glasses plus 6 on the cylinder.
the anisoconia is there, but still you have improved.
So will the child still use both eyes if there is so much of anisocenia?
No, the child is using both eyes. Well, that's why you have a stereopsis present. The child is not using both eyes. You won't have Hertzford dot fusion. You will not have stereopsis.
So how do we know if the child is not having diplopia?
Child is not having diplopia. Child will complain of diplopia. It's only an anisometropy of 4. Diplopia happens with a larger anisometropy. It's 1 in one eye. The other eye is +5 with a cylinder of 1.5.
Once you stop the occlusion, does it recur? The possibility of amblyopia?
Possibility
of amblyopia?
Yeah, the possibility of recurrence is very high if you abruptly stop it. The moment the child achieves 20 by 20, you stop it, you say that's it, then you will have recidivism act. But if you taper your patch up, it won't happen. But the key to all this is proper refraction. No amount of amblyopia therapy will happen if you give a wrong refraction.
That's the key.
After this point, for how long will we follow it?
Not
At 6
talking
months.
about
6 months till what age?
Coming to childhood, like how you ask your pediatric patients to be followed up, even a normal patient who's wearing a refractive error, you ask them to come at the year of 6 months. Similarly, you follow up these patients.
A lot of talking happening in the first
Yeah,
month.
Dr. Kala wants to know because whether a surgical clear lens extraction will help because she feels
Definitely
that.
not. Definitely not.
Whatever you do,
Never
how
in a
much ever you attach the amblyopia or anything, finally you land up in +5 and +1 only, right?
The patient
The
loses
child,
accommodation.
this is a child, the hyperopia is going to come down as the child age increases. And
What is
are
the age
you
of the
going to
child? Sorry, I missed the first
6
part.
years.
6
You
years.
cannot do a clear lens extraction in a 6-year-old child.
That's where the discussion really helps,
And till what age would you try this thing, amblyopia treatment? Till what age?
Amblyopia treatment is over once the visual acuity reaches 20 by 20 and then you taper your patch.
Yeah, till what age would you
You keep doing it at the entire childhood. No, what other thing is
presenting age, I mean, the presenting age of the child, till what age would you go in for?
that I will is there in the discussion.
Okay.
It's up to 8 years.
8 years.
But there is a period where you can extend also.
Okay.
Shall we go on to the main presentation? Shall we go on to the main presentation?
Any more questions? I mean, we have a minute. We have a minute more if anybody has any more questions, minute or two. No. Anything to clarify on the case? Yeah.
I'm supposing this child is like myopic, severely, highly myopic, at the age of 6 years, having this anisometropic myopia, and instead of giving glasses, I mean, you can say myopia is around 12 spherical equivalent, and other eye 6.
Two
Plano.
options are there. One is contact lens, the other is refractive surgery.
Yeah, that is
If
what
you
I
have
mean.
anisometropy of more than 6 diopters happening and it's myopia, you can always endure refractive.
So the advantage of that will be like amblyopia treatment will be, amblyopia will be fastly corrected. In
Amblyopia,
comparison to
yeah, the
glasses.
amblyopia treatment would be more effective, or we would say it takes little lesser time for the improvement to take place. Once you have the anisoconia, but the same thing is done with contact lenses. Suppose your patient is not affordable or the patient's parents are not willing for a refractive surgery, please push for contact lenses for any case of significant anisometropia. The improvement is faster and the progression is better. Okay, shall we go on to the next presentation? Okay, now we'll go on to broadening the view of amblyopia. So what is amblyopia? The simplest definition that amblyopia can have. Amblyopia is just a developmental disorder of spatial vision, which simply means an amblyopic child is not able to see something in space which you and me who are normal can perceive. So what is the classical vision parameters? People say, is it best visual acuity less than 20 by 40? Is it a 2-line difference in visual acuity? Or is it even a best visual acuity of less than 20 by 20? Well, all three definitions will fit into amblyopia. Okay, now this is the visual pathway, but what I would like to emphasize is all of us know there's the optic nerve, then you have the optic chiasm, the tract, the LGB, the radiations, and the striate cortex. But this little small area over here, which is B5, this has been recently discovered by the National Eye Institute studies, and this has got a very useful role in the pathogenesis of amblyopia. This is just to show what are the cortical sensory adaptations that happen in amblyopia. A normal patient would have a large percentage of binocular cortical cells with also equal representation of monocular cortical. With also equal representation of the monoocular cortical cells. But what happens if there is squinting in one particular eye? If it's not a freely alternating squint, what you have is the binocular cells keep coming down. See how much it is reduced. As well as there is some reduction in the monoocular cortical cells. But if you have something like a meridional amblyopia, or if you have something like high plus power, equal kind of plus power in both your eyes, then you find that your binocular cortical cells still remain. It is just that only there is a decrease in the monoocular cortical cells. Okay, are not just functional changes in vision. Amblyopia is also associated with anatomical changes in the brain. Now this is the left eye where you find that the number of layering in your lateral geniculate body has come down as compared to the right eye. And also the striations in the striate cortex is far less in an amblyopic monkey as compared to a normal one. Okay, so I want to emphasize on the plasticity of periods of visual development. There's something called as a critical period which happens from birth to 6 months. This is when all your cellular connection, your binocular cortical cells, your monocular cortical cells keep improving. So in this critical period, if you have deprivation, if you have distortion of vision, you're going to have a dense amblyopia going to be manifest. There's something called sensitive period, which is 6 months to 6 years, 8 years, and this is the period when you can modify your amblyopia, where treatment is sensitive. There is also a susceptible period between 8 to 18 years, but what you have to remember is that there is a residual plasticity period which is going to start at 18 years and it is going to go up to mid-adulthood. Okay, amblyopia is not just decrease in vision. Beneath the surface, you have a lot of other functional abnormalities which you can expect. One is decrease in contrast sensitivity, spatial distortion, abnormal spatial interaction, crowding, loss of accommodation or decreased accommodation, abnormal smooth pursuits and saccadic eye movements, suppression, interaction of spatial and temporal functions. So is treatment of amblyopia just based on observational data? It is necessary but definitely insufficient. You need far more kind of in-depth analysis of amblyopia. Okay, that is why the National Eye Institute came into being, and it started the PEDIC trials, or the Pediatric Eye Disease Investigator Group of Trials, which is a multicentric, randomized, controlled trials involving private practitioners and institutional practitioners. The first study came out in ophthalmology at 2003, and that was what is the patching regimen which you will follow for in treatment of severe amblyopia in children. This is the first study. So the results of this study said what people were following for severe amblyopia is full-time patching. So after this study was published in ophthalmology, they said that there is no longer full-time patching that is necessary. You can do away with 6 hours of patching in severe amblyopic children. This is the first study published by Ophthalmology Journal long ago in 2003, and it still holds good because we do not do full-time patching for severe amblyopia. When I mean severe amblyopia, I mean a visual acuity of 630 and less. We only do about a maximum of 6 hours of patching. The second study was on moderate amblyopia, and this was published in the American Journal of Ophthalmology in 2003, again in 2003, and this study showed the results with atropine penalization as against to patching. Now, as far as the results of this study goes, you had improvement of visual acuity almost equal in both groups, whether you did patching or atropine penalization. Both cohorts of patients had equal visual acuity, but its improvement was faster with occlusion as compared to atropine. Now the next study was, is daily atropine needed? This study was the randomized trial of atropine regimen in ophthalmology in 2004. They compared daily atropine versus weekend atropine, and the outcome of results after 17 weeks said that both children had similar outcomes. So there is no reason that you have to persist with daily atropine therapy, but you have to persist with weekend atropine therapy. Now, treatment of amblyopia in older children. We tend to treat children only up to the age of 8 years. Or that is the general mind concept that amblyopia therapy does not work in older age group. That is the reason this randomized trial published in the Archives of Ophthalmology in 2005, it took children between the age group of 7 to 17 years. This is the plasticity period, and they found out if children between 7 to 12 years, amblyopia therapy worked if amblyopia was not addressed, even if it was addressed previously. And between 13 and 17, amblyopia therapy worked only if amblyopia treatment had not been addressed previously. So you got this point? So between 7 to 12, amblyopia therapy will work even if children had amblyopia therapy in the past. But between 13 and 17, you will have better results only if the child had not been treated in the past. Okay? So then the next study was anisometropic amblyopia in children with refractive correction. This is in 2006, published in Ophthalmology Journal, and you have children between 3 and 7, visual acuity ranging from severe to moderate visual loss, and the only treatment that was given in this cohort of patients is just spectacle treatment. And at the end of 30 weeks, you found significant improvement with just glasses. So what is the conclusion of this study? Glasses alone is a powerful treatment modality in young children with anisometropia, and in moderate cases of amblyopia, it may be the only treatment that is necessary. Now there is a phase 2 of this study, again in Ophthalmology 2006. After the completion of first phase, you have two subsets of patients, one undergoing patching with near activities, the other which did not undergo patching and near activities. And you find that there was additional improvement in patients who had the patching group. Okay, so how do you manage patients with amblyopia? Appropriate glasses. This is very important. This is the first step, giving proper refraction. Quality time patching if it is moderate amblyopia. You have a belt and suspenders approach to atropine. What do you mean by belt and suspenders? Use atropine for some time, you find that the reverse amblyopia is happening, you have to stop atropine. And patching is moderate. Refractive amblyopes, you can give home-based visual training exercises, but in strabismic amblyopes, you need more vigilance because they are prone to regression, and that's where the fortified amblyopia therapy comes into being. Okay, these are the tips for successful management. It's called undoing the occlusion confusion. If there is severe amblyopia, you have to give direct maximal occlusion, moderate minimal occlusion, shallow amblyopia, no occlusion at all. Always emphasize on the value of glasses and near point activities. What are the issues in compliance with patching? You find it very difficult to motivate children because it doesn't make sense to a child. Why is the better eye patch? And children of all ages are concerned about their appearance, and children are always adept at treating the system. What are the different methods of occlusion? You have opticlude patches, plastic occluders, patches, which can be stuck to your glasses. Now we look at amblyopia as a developmental disorder. It's a developmentally disabled eye. So you can teach this eye to perform better. And that is what is the concept of perceptual learning. So how can you train the eye, visually train the eye? You can use Heidegger brush stimulation to stimulate the macula. You can improve accommodation by accommodative stimulation. You can use to improve the ocular motor precision control by using small detailed targets, reduce the crowding phenomenon which is present in amblyopia, improve spatial localization. It is not, that is why all these near vision, the vision training is so very important. It is just not about only patching and forgetting about the child. Then you will not get any improvement. So there is a concept of monocular fixation, binocular field. What is this? The amblyopic eye will be preferred to function centrally, whereas the other eye will function peripherally. This is like an analogy to picture-in-picture TV screen. Now, one of the things for MFDF is you can use foggers like the Bargetter foils, which can occlude the other eye, but it does not completely deprive the eye of vision or light. It will just drop the vision to below the amblyopic eye. Atropine penalization paralyzes accommodation as well as the dilatation of the pupil, will induce aberration and also reduces the depth of focus at all distances. Again, here we are going to achieve a vision which is lower than the amblyopic eye. There is something called as supervised perceptual learning under MFDF. Now you use anaglyphic filters or polarized filters. You have red-green filters. The good eye is going to have the red filter, the bad eye is going to have the green filter, and your print is going to be in red. So what happens? The child is not going to see with the good eye. All the print is going to be appeared clear, blanched. But the green filtered eye will see the red print, and you ask the child to track the alphabets. So you can see in this paragraph the child has tracked the alphabets, and the eye which is going to guide the normal eye is the amblyopic eye. So the preference is to the amblyopic eye. All these things are done under binocular conditions. So this is like a biofeedback, and you have better improvement in amblyopia therapy. So So the last and the final thing which I would like to say, which is there in our hospital, is computerized therapy to amblyopia, which is the AmbiNet exercises. You have a whole array of programs for the child to perform. And what is this exercise so very different from the normal things which you do? And when the child starts doing this, the child is going to be adept at looking at one of the phenomenal changes which is happening in amblyopia, that is crowding. So the vision improvement, the quality of vision and the amblyopia therapy is going to be better. Find the target. So as the child keeps doing the exercises, the targets keeps getting reduced in size. So the child is going to have ocular motor precision control when the child is going to find a target of reduced size. So windows of opportunity. This is the last phase of my talk. The windows of opportunity in treating amblyopia. Yes, amblyopia can be addressed. There is a sensitive period, 8 years. You are going to do patching, but you have other modalities of providing biophone feedback and perceptual learning. But age alone should not be used as a limiting factor for amblyopia. Okay, this is the final take-home message. And what about wonder drugs? There are so many things which are happening. There is levodopa, carbidopa, which is being studied. Now the study is going on by ATS for levo-carbi combinations. They all improve the axonal neuronal stimulation. But what you have to remember, they can be only used with adjunct to other forms of amblyopia therapy. Levo-carbi is suggested only in children more than 8 years, but we have the other one, the citicoline, which can be used at a younger age group. And amblyopia therapy is just like pieces of a jigsaw puzzle. You fit in perfectly, you get a perfect picture. Thanks for your patience.
I'm sure that there are a few questions. I have a few myself, but before me, I think it's important to get the crowd to start asking their questions. So, anybody has any questions regarding the talk or amblyopia?
Do we have patches in our hospital?
No, but it's available at burnal.com and you can use it. But it's not necessary because,
Because sometimes when we give this optic patch, yeah, optic fluid is there, but that's
but you have something which is like a skin.
that can be worn on the glasses also.
After they remove it, to apply coconut oil or some kind of moisturizer, that works better. Because immediately I see like some children come with that patches
look
and
down.
they try to build up or they do this and stuff. So that looks actually works.
And one more. Well, this amblyopia eye-net exercises, how long do you recommend? Is it for the same period as what you recommend for the occlusion
Like
therapy?
no. Atropine therapy, you have to look
Occlusion.
at 6
6
months,
months.
4-week follow-up, and as soon as the vision is this thing, you can taper it and stop it. It's just like patching. Whatever you do for patching, the same applies.
So
Those
that
are the ground rules for patching.
So you give it as a home-based thing and you assess after 4 weeks.
You keep calling the patient at 4 weeks.
Okay, thank you.
One is just for the interest of the postgraduates. If the amblyopia is associated with squint, then what would you treat first and why?
Actually, there are a lot of controversies regarding this, but what I actually do is, I see that there is equal fixation. Suppose you have a child where the fixation is not equal, then you are at a roadblock. When there is equal fixation with both eyes, you can start off with your strabismus therapy and then go on, continue with your amblyopia therapy. Especially in an institutional practice like ours, actually we don't have dropout of patients. So they keep coming for a follow-up. The reason why people said is you first treat amblyopia and then do strabismus because of the larger dropout rates happening peripherally. But in an institutional practice, it doesn't matter because there is a roadblock if the strabismus is still existing. So it's better to treat your strabismus once there is an equalization of fixation in the eyes.
The second question is regarding patching. So, like when we were taught that the patching depends on the age. So if it's a 1-year-old child, it's 1 in 7.
See, now
2-year-old child, 2 in 7.
follows
So how much?
study.
Yeah. So how much
That
is
is
the
for
patching?
full-time patching, which
Correct.
is not done any longer.
So now
Even for severe amblyopia, it's only 6 hours. So now what we follow is the pedic trials. You don't follow the age-old concepts.
And ma'am, with regards to the treatment of amblyopia, you said that the older age group, they tend to not respond better if they've had the previous amblyopia therapy.
This is
So what
what
is
the
this
study.
So what is the
What
rationale
the study
behind?
says is, you can still try. But
But
what
what's
is
the rationale behind it?
No, they found out in the study. They had children between 7 to 12 years. There's another group between 13 to 17. And the conclusion of the study was this. So it doesn't mean that you follow it. You can still treat your amblyopic patients up to 17 years. But you just keep it at the back of your mind. If a scientific study has told you that, then you don't expect as good a results if the amblyopia has been addressed previously.
And last question, ma'am, what's the role of functional MRI in amblyopia?
I don't know. I have not done it.
First of all, congratulating the whole clinical team and Ashwin for this. I don't see this kind of crowd in any long before that, I wanted Divya Ashok here. We started something called amblyopia. Have you gone through it?
Yes, ma'am. You told me to go through it, ma'am. I have done it.
How come you didn't? That's why I wanted it. I wanted Divya Ashok here. We tried and proved that amblyopia is not true. It is amblyopia. It got accepted in American journals also. And we tried to prove that this is due to higher order aberrations in older age group.
Ma'am, if you
that
have
answers
a
Anusha's
roadblock,
question.
like if you have your refractive correction and then you find that the child is not improving, then you think of amblyopia. Look
Because
at
some of
higher
these
order
children are left alone. We are taught right from the beginning that within 5 years, if we don't treat the amblyopia, that becomes a permanent amblyopia. We disproved that. We took so many cases and we did LASIK and we did clear lens extraction and we gave them 3 to 4 lines of improved visual acuity. So that's what I wanted to say. Can I leave now? I'm in my braces.
Thank you, ma'am.
Thank you, ma'am.
Dr. Manjula ma'am, you have any questions to ask for amblyopia before and now?
First of all, an excellent presentation and quite refreshing for my old brain. So the only thing probably it is out of the syllabus of today's talk. We also have this deprivation amblyopia when there are some corneal opacities, birth trauma or some
Those
such
are
thing.
severe kind of.
In that kind of case, how would you manage such a child?
Ma'am, the thing is, suppose you've had a corneal opacity and you've done a penetrating keratoplasty. The biggest roadblock here would be your irregular astigmatism. So that, because we are not going to have a proper kind of a refraction possible. Maybe we'll have to give something like a rose scale lens or a mini scleral lens to counter that component. Then your amblyopia therapy would definitely, but definitely this will be a very dense kind of amblyopia. Direct maximal occlusion would be the way of going about it. Longer term follow-up. Maybe the results, final results of your visual acuity will not be that very promising. But definitely there is scope for improvement. We have to try amblyopia therapy.
Dr. Anusha has one more question. Anybody else has a question? I think we have 2 questions. Yeah, I'll come back to you.
How do you calculate the number of hours of occlusion? You said 2 to 6 basically.
No. In severe amblyopia, you do 6 hours. Okay. If it's moderate amblyopia, you do only 2 hours.
Okay. So
if it's minimal amblyopia, you don't have to patch it off.
Okay. So some children just won't accept the patching.
So that is when like you other modalities have told you, atrial penalization is one such. And you have this barbarator foils, which is, you have MFBF kind of exercises, so many other things. So our alternative modalities.
Right. What I wanted to know was, is 2 hours still all right? I mean, if a patient cannot manage 6 hours of patching, even in severe amblyopia, will 2 hours help?
2 hours is definitely not going to help. You have to emphasize on 6 hours if it's a severe thing.
Ma'am, what is the period beyond which you say like this is the maximum improvement, it won't improve beyond this?
You can keep on trying up to 18 years. Why should you give up on your patient?
Like I've started treatment today, so do I wait for 16 weeks, 6 months?
No, actually as I said 24 weeks. By 24 weeks you see. If you are not seeing, there is something going wrong in your treatment. Either the child is non-compliant or your refraction is totally not adequate. So you have to look at each time the child comes, you have to see, why is my child not improving? If a child is going to come with the same 6/18 for your entire 6 months, then your refraction is wrong. Most probably that is.
So 6 months is the cutoff when you decide that yes, the treatment is
No, every 4 weeks you are bound to see some improvement.
The last.
Yeah. It again depends on where you started with. In my case, the patient has 6/20/70, that means 6/19 vision. So if it's going to be 6/60 or less, it may take even a year. But you will see improvement. You will see a progression. At every follow-up, you will have to monitor for progression.
And the 6 hours patching can be in parts or has
No,
it
the
be
6 hours patching, it's better to be as a continuous.
Understood. You
do a
We do know the
definite cyclo-
questions can be asked to the other panelists also.
Next one is there.
One more question. Okay, Preeti, just before you ask that one, just one.
Can we use atropine for severe amblyopia, and if not, why?
Atropine for severe amblyopia may not give adequate results. For severe amblyopia, it's direct maximal occlusion. It works better in moderate amblyopia.
What is it? What is the? I need to know what exactly. Do you recommend atropine refraction first or cyclorefraction? What is the age? What? How do you determine this is the right refraction? Or is it
Refraction is a different topic altogether.
No.
It's not within the scope of today's talk. But in children, you need to do a cycloplegic.
till what age and what means? I just want to know this because we are seeing a 6-year-old child.
Yeah, hypermetropic children at all ages, up to 16 years, even adults, you can do cycloplegia.
Okay.
Okay, hypermetropia, cycloplegia is the norm.
Right.
Now, children, that is basically up to 16, pediatric population, cycloplegic is a must.
Till 16, all refraction,
yeah, all
recommend
refraction
cyclo.
to be done with cycloplegia.
Cycloplegia.
Hypermetropia, even in adults, cycloplegic, yes. And any patient at any age group with accommodative problems, okay, then they have accommodative asthmatia, they have eye strain, then you look at cycloplegic refraction.
In a 4-month-old child, unilateral cataract, you have done the surgery.
Okay.
After surgery, you want to continue with the patching for the other eye.
Yeah.
So, how do you follow up the patients, and what are the things you look for when the patient is coming for follow-up?
See, 4-month-old child, first you have to look at alternation of fixation. That is the thing. Because this child should be able to look at your target without resisting occlusion. That's a way of indicator. And the second thing is, if there is strabismus, there should be alternation of fixation. And the same way, 4 weeks you have to keep following up the child, and each time you look. Other things you can't basically. Your dilated fundus examination should be normal. Your refraction should be okay. And each time you look at the subtle monitors. Or you can just give some colored objects and ask the child to take up. You look at indirect indicators of visual acuity. Like, this is also another topic because this will come to how do you assess children in a pre-verbal age group. So that's what you basically do.
This debate will go on for another 3 minutes, so please keep your questions ready. I have one
Is
more
the,
coming up here.
Is the 4 weeks time duration like it is forever, or like if we feel improvement is there, we can increase the time duration or follow up?
It's up to you, but I think 4 weeks is what generally is the norm which is followed.
The second thing, like in a patient who is anisometropic, in a child like say 5 or 6 years, and we are starting, and child is like wearing glasses for the first time, should we first start the glasses, let the child adapt to it for like say 2 to 3 months, and then
Not
go for
3
the
months.
amblyopia?
You call the child at 4 weeks. Why 3 months? Don't delay the period yourself. Call them at 4 weekly intervals.
We have one question here.
Ma'am, you spoke about citicolin. Ma'am, what is the minimum age to start citicolin and how long do we give it for?
Citicolin is a drug which you can give earlier. For as far as levo and carby is concerned, you give it only after 8 years. But Citi can be started earlier. For children who are going to be like very small children, you can give 250 milligram per day. This will be maybe age group of around 6 years. More than 6, you can even give up to 500 milligram. Body weight also. You can just see the calculation of the dose. Body weight is also.
So how long?
You do it as an adjunct of patching. So however long you're doing your patching, that much period of time you can put the patient on citicolin.
And ma'am, any difference in dose in moderate and severe amblyopia?
No, the dosage is the same. Because moderate severe is your patching regimen, which is good.
I have a question. In a child with isoametropic amblyopia, hypermetro, best corrected vision in one eye say 660, other eye is 636 after glasses. Is there a role for alternate patching?
No, there is no role for.
So what do we do in those cases?
These are ametropias cases. You just give the optimum refractive correction and you just keep following up the patient. Suppose the amblyopia is going to be very like maybe 630, you can do alternate patching. But if it's going to be around 612 with your ametropic correction, you can just there's no need for any patching.
I have a question. Suppose a child has been through one sitting of Ambinet, the 6 months therapy, but after a few days you note a drop in vision, and then do we repeat? Can we give
Actually,
Ambinet?
no, it's all about tapering the treatment.
If you taper, this recidivism never comes.
So
All
even
the
ambulance has
regression
to be,
happens,
tapered.
yeah, everything has to be tapered.
Okay. So tapering means beyond 6 months, or how long do you
No,
actually advise?
actually the ambient therapy which we have here is only for 3 months. So it has to work within 3 months.
I have one more question. If the amblyopia is dense, as in one eye has 1/60, 2/60 vision, then how do you go about the occlusion? Because occlusion will hamper the
These
daily
cases of
activities of
very
the child.
dense amblyopia, what you're talking about are eccentric fixation.
Okay.
You look at your central fixation, it will not be central, it will be eccentric. That is why the vision is 1/60. Many times we have minus 16 diopters, but it's not central fixation.
So what do you do with these children?
You need to stimulate the macula. Either the macula image tracking or the Heidegger brushes, something you have to stop.
I have one question for you, ma'am. Could you tell us more about the pediatric smile which is happening in your department? Is it helpful for treatment of amblyopia, or how do you decide, and what are the? Has it helpful?
Yeah, definitely. This is what we have discussed prior to your question with madam. Refractive surgery or refractive laser, whatever it is, okay, not only smile, it has worked wonders for the patients who are anisometropic, who are having anisometropic amblyopia. So there are very few selective patients whom we have to select for the refractive surgery, not all. Firstly, the age of the patient, because the patients are not compliant with the glasses. They cannot be treated for amblyopia with the glasses. They are not compliant with the contact lens, and they are having severe amblyopia and severe anisometropic amblyopia. Those patients are the patients we will select for the refractive laser. And in refractive laser also, people say that it is always better to opt for procedures like photorefractive keratectomy or procedures where anterior stroma is least hampered. And now the newest treatment is smile, although it is not FDA approved for the pediatric LASIK, but still I think it can do wonders for those kind of patients.
After this smile, when we opt for a PRK, the retreatment at say 18 or 20, when they have a regression or a residual power, is easier. In smile, generally, how do you augment? Is it like the adult smile, you have to do a PRK, or?
Residual.
See, suppose we do a smile at 3 or 6 years of age or whatever.
Okay.
We definitely know that they are going to end up with an additional refractive error at around 18 to 20. How do you treat that if you have done smile?
See, it depends from what power we have corrected. When the age, like for pediatric, what power we have corrected. It depends on that. What is the power? And secondly, what is the power the child or the person is having at the age of 18? What is the corneal shape? What is the residual thickness? It depends on that. I think majority patients that we select for pediatric LASIK, they are having power of spherical equivalent more than 14 or something like that. That is what I have done. So in that range, definitely at the age of 18, again, refractive laser is not an option. Actually.
Okay.
So mostly all those patients will go for the ICL.
For the ICL.
And this is basically for this age, if we are selecting pediatric LASIK, that is the last resort actually. Because that is just to give fast treatment to the amblyopia that patient is going to land up or is already in. Just like that.
Okay, thank you so much.
March 13th, and we have team leaders Dr. Nalini and Saraswati who will be coordinating and doing the next grand rounds. So all the questions were beautifully handled, and I know with what elan and attitude, I just can't help. Thanks a lot. So big applause for them. According to this introduction, I have raised a question: is this going to be any different from the journal club? The grand round, this is any different? I think you got the answer. It is us, you, me, we who can make the difference. We want every one of you to participate, bring about the questions. It can be the silliest of doubts, but I think it's better to make our mistakes and learn from this forum rather than do it on the patient. So thanks a lot for this overwhelming response, and thank you. Nothing more to say.
Thanks for coming, guys. Just a couple of things, So I think we should respect the speakers and the panelists because they were here before time. In just the interest of time management and making sure that grand rounds go on as per schedule, because I saw a lot of people while the presentation was going on walking in and stuff like that. It didn't actually look good for the speaker as well as the panelists. We're trying to set a standard here. Over a period of time we will be closing the doors like an auditorium, and post which I don't think we'll be allowed inside. So try and be there before time. I would presume a 10-minute prior to time so that you can interact with the panelists and ask different questions. Come, because we've given the topic a week or two in advance, come prepared with your questions regarding that topic. It really helps in enriching your knowledge and also knowing from our side what we should be preparing for the next time going forward, and that kind of brings the whole culmination of education to the next level. That's having been said, we are keeping this only once a month, so it's not going to be too taxing for you guys to make that once a month calendar schedule in your calendars itself. Please be there on time, 10 minutes prior. We will be soon in the next couple of sessions shutting the doors. Another thing is about the PGs. PGs, whether you have fever 104 or 105, you still have to be here. You can take off after this. It is a mandate henceforth. There will be no more excuses. Please inform whoever has not come. The only reason that you probably are not here is if you have another duty somewhere else, and that's probably understandable. But otherwise, I think they have to be here, all of you. Thank you very much, and fellows too. Fellows also. Thank you.